Hello everyone, welcome back to Tutor Series. My name is Shujauddin and in today's lecture we're going to talk about nephrotic versus nephritic syndrome. So before we go on to the details, let's just have a brief overview of a bit of physiology and then we'll move on to the pathology. So when we talk about the basic functional unit of our kidney, our basic functional unit is basically the nephron, right? That makes up our kidney. Multiple nephrons make up your kidney. Now starting with the nephron, you have your glomerulus which is sitting inside the Bowman's capsule, which then becomes the proximal convoluted tubule, after which it goes into the loop of Henle. Then you have your distal tubules, and then you have your collecting ducts. So this is what our nephron looks like. But today we're just gonna look at our glomerulus, because nephrotic and nephritic syndrome, these both are glomerular diseases, right? So over here you have a glomerulus in front of you. This part is basically resembling your normal glomerulus. So in the normal glomerulus, what happens is that you have blood coming from your afferent artery, then it divides into different capillary loops that makes up your glomerular tuft, after which it becomes combines and makes up your efferent artery. Now afferent artery brings up blood, that blood gets filtered, the useful material is kept inside the blood, the waste material leaks into the urinary space, after which our blood gets filtered and the filtered blood then returns to the body through our efferent artery. This is what happens in a normal human being, right? So let's have a look at the glomerular tuft. So this is basically your capillary lumen, right? This hole is resembling your capillary lumen. You can see you have our RBCs, you have serum proteins. These blue dots are resembling our serum proteins. So let's have a look at the barrier that filters our blood and keeps the useful material inside, and the waste material gets leaked into the urinary space. So let's look at how does that happen. So the first layer, going from inside towards the outside, this first layer that we have in black is basically your endothelial layer. Capillary endothelium is resembled by this black layer. Now our capillary endothelium has 70 nanometer to 100 nanometer fenestrations in between it. So the first barrier is going to be your endothelial layer. After this endothelial layer, the second barrier that is going to come after it is your glomerular basement membrane, GBM. Now glomerular basement membrane normally has a charge on it which is negative. Now this will have a negative charge on it. Now the reason why does the glomerular basement membrane have a negative charge on it, because our serum proteins normally are negatively charged. Now when you have serum proteins coming into the glomerulus, this basement membrane is going to repel these serum proteins and keep them inside your blood instead of making them leak out into the urinary space. Because if you were to leak out a lot of protein inside your urine, you would end up with nephrotic syndrome. So you need to repel these proteins, and this is done by the negative charge on the basement membrane. Our basement membrane has 3 layers. It has a middle layer that is dense, and it has a less dense layer on the outside and the inside. So it is made up of 3 layers: lumina interna, lumina densa, and then your lumina externa. Now after this basement membrane, you can see these cells that are green in color. These cells are basically your podocytes or your visceral epithelial cells. Now these podocytes, they have filtration slits in between them. They have food processes and filtration slits in between them that are 20 to 30 nanometers in size. So we started with our endothelium with 70 nanometer to 100 nanometer, and when we went reached our podocytes, you had a filtration slit of 20 nanometer to 30 nanometer. So what happens is that these 3 barriers, they try as much as they can to keep the useful material inside. So let's say if anything were to leak out, let's say a protein were to leak out through your endothelial layer, because 100 nanometer is a bigger size, right? Smaller proteins can leak out. The basement membrane is going to repel those proteins and they're going to stay inside. But let's say you had a neutral particle that were to escape the basement membrane as well, because if it is a neutral particle, the charge won't affect it. Even if it were to escape, the podocytes usually just have 20 nanometer space available, and that won't allow that particle to escape. So the 3 things that keep the useful material of our blood inside our body are starting from your endothelial layer that has 70 nanometer to 100 nanometer space in between them. Coming on to the second layer, that is your basement membrane, which is negatively charged to repel proteins. And the third thing is basically your podocyte with filtration slits of 20 nanometer to 30 nanometer in between them. So this is what makes up your barrier inside your glomerulus. Now, if anything were to happen to this barrier, you would end up with nephrotic or nephritic syndrome. So let's have a look at nephrotic syndrome. What's going to happen there? So let's have a look at nephrotic syndrome. That's what is going on in the nephrotic syndrome. So this was our normal glomerulus, right? Now let's have a look at this glomerulus and see what's wrong over here. So we're gonna go from inside towards the outside and see, like, where does the pathology lie. So the first layer that we're going to come across is that we have our capillary endothelium. Now, if you look at the capillary endothelium, it's similar to the normal one. That means there is no pathology here. So we're good to go on that. Now, coming on to the next layer, that is your basement membrane. Now, in basement membrane, we said that the normal basement membrane is going to be negatively charged to repel the proteins. But over here, we're seeing that the basement membrane has a positive charge on it. Now, if you have negatively charged proteins inside your glomerulus and you have a positive basement membrane, instead of getting repelled, these proteins are going to get attracted towards the basement membrane. So they're going to come over here. Now, secondly, let's have a look at the podocytes. This is what the normal podocyte looks like. But if you see, these podocytes are effaced. They are fused. They're effaced in nature. They have lost their normal structure. So what happens in nephrotic syndrome mainly is that you have loss of podocytes, you have effacement of your podocytes, and with that, you also have a reversal of the charge of the basement membrane going from negative to positive, which is why you have a lot of leakage of your serum proteins. You end up losing a lot of serum proteins. So let's list down the things that happen in nephrotic syndrome. So the first thing is that you have protein loss. And this protein loss is really great in number. How great? It's greater than 3.5 grams per day. You're going to lose a lot of protein. Now, the most common protein in the human blood is albumin, and albumin is small in size. So the first protein that you would lose, and you would lose in excess amount, is going to be albumin. So what are you going to get? You're going to have hypoalbuminemia in your body with albuminuria in your urine. Now, if you lose a lot of albumin, what's going to happen is that your oncotic pressure is going to decrease, because the proteins maintain your oncotic pressure in the body, right? So due to hypoalbuminemia, you will have low oncotic pressure. Now, low oncotic pressure is going to lead to what? Think about it. If you can't maintain your oncotic pressure, you'll end up having a lot of water retention inside your body. That will lead to generalized edema. So patients of nephrotic syndrome will have generalized edema in them because of loss of protein. And you, like I mentioned, you have a greater amount of loss of protein that is greater than 3.5 grams per day. So you will have generalized edema. With this, you also have sodium and water retention because you have release of aldosterone. Now, sodium and water retention is going to further worsen your generalized edema. And if it is severe in nature, you might end up having massive ascites and pleural effusion as well. So these are a few complications that you need to keep in mind. Now, albumin was one kind of protein that we talked about that you will be losing, right? The other kind of protein that you can lose is going to be your immunoglobulin. Now, if you use immunoglobulins inside your urine, what's going to happen is you won't have anything left to protect yourself from, right? If you have infections, immunoglobulins are going to protect you from that. But if you lose those immunoglobulins, you will have a lot of opportunistic infections happening. So patients who have nephrotic syndrome, they are at risk of infections. Now, after losing immunoglobulins, one thing that happens is that due to loss of proteins, your liver starts to compensate for the loss of proteins by making high amounts of lipids, high amounts of fats. So if your liver is going to start producing increased amounts of lipids, what will happen to the lipid level inside your body? You will have hyperlipidemia. Now, hyperlipidemia is going to cause lipiduria. So in nephrotic syndrome, you get lipiduria and you get fatty casts present inside your tubules. So this is a really significant finding in nephrotic syndrome. Now, another thing that can happen is that you also end up losing antithrombin 3. Antithrombin 3 is basically a particle that prevents thrombosis inside your body. Now, if you lose antithrombin 3, what will happen? You will be at risk of developing thrombosis. So in patients of nephrotic syndrome, you have a higher chance of having renal vein thrombosis. Now, increased chances of renal vein thrombosis, it's only going to worsen your situation, right? So let's have a look at, like, what happens in nephrotic syndrome. You have a protein loss that is greater than 3.5 grams per day. In the protein loss, what are the common proteins that, you end up losing? The first is going to be albumin. You will have albuminuria, due to which you will have low oncotic pressure, leading to generalized edema. You also have sodium and water retention due to release of aldosterone that can, promote to ascites and pleural effusion in a patient. You can also end up losing immunoglobulin. Now, the thing is that if you just lose albumin in a patient of nephrotic syndrome, that means that you have selective proteinuria. But if you also lose globulin, globulins are basically larger proteins than albumin. That is when you call that the patient has non-selective proteinuria. So we'll see what diseases come under nephrotic syndrome that have selective proteinuria and what have, non-selective proteinuria. But if you lose immunoglobulin, you will be at risk of developing infections. Liver compensates for the loss of proteins by making increased amount of fats that can lead to hyperlipidemia and lipiduria. Lipiduria will then lead to fatty casts present inside your tubules. So you will have fatty casts present. Apart from that, you also end up losing antithrombin 3. Antithrombin 3 prevents clotting inside your blood. So if you lose antithrombin 3, you will be at a risk of developing renal vein thrombosis. So just to see that this is your normal glomerulus compared to the nephrotic syndrome glomerulus, the two things that are different is that you have reversal of the charge and you have effacement of your podocytes. These two things happen in nephrotic syndrome, and there are multiple diseases that come under it that we'll be discussing in the next few videos. So let's have a look at nephritic syndrome now. So we talked about two glomerulus. We talked about the normal one, we talked about the nephrotic one. So the last glomerulus that we have left to discuss is nephritic syndrome. So let's have a comparison between the normal glomerulus and this glomerulus. We're going to go in the same way from inside towards outside and see where is the pathology. So the first thing here that we'll be noticing is that the endothelial layer, right? That is the first one that comes. So if you notice the endothelial layer, it's damaged over here and it's completely absent throughout this part. So the first thing that happens in nephritic syndrome is that you have damage to your endothelial layer, you have breakdown of your endothelial layer. So that is the first thing that's happening. Now coming on to the basement membrane, that comes after the endothelial layer. So the basement membrane is also absent, it's also broken on multiple parts. And the third thing, that is your podocytes. So if you notice, your podocytes are also irregular in shape, and they're also reduced in number. So all three of your barriers, endothelium, your basement membrane, and your podocytes, they're all damaged here. So how do they get damaged? The first thing that happens over here is that nephritic syndrome is by definition called inflammation of your glomerulus, right? So whenever you have inflammation, what is going on? In inflammation, you have neutrophil mediated damage, you have cytokine release, so you have cytokine mediated damage. So neutrophils, they're present over here, and then you have these immunoglobulins as well. They're releasing cytokines, your neutrophils are releasing cytokines, so they're all mediating a damage against what? Your glomerulus. The glomerular layer that is present inside the glomerulus, they're all mediating a damage against it, which is why they have destroyed the endothelium, the basement membrane, and your podocytes. So if you notice, you have no barrier whatsoever left over here. Over here in nephrotic syndrome, you still had your endothelium intact. So you just had damage of your podocytes and a reversal of the charge of basement membrane that led to the loss of proteins, right? Now over here you have no barrier left at all. So you're going to have leakage of your serum proteins as well as your RBCs. So when you have loss of RBCs inside the urinary space, you will have RBCs present in the urine. So we'll talk about what happens in nephritic syndrome. Let's just have clear look at the glomerulus for now. So you'll have loss of RBCs, serum proteins, and everything because you have cytokine mediated damage, neutrophil mediated damage going on inside nephritic syndrome because you have inflammation of your glomerulus in nephritic syndrome. So what will you have in nephritic syndrome? As you can see, you have loss of RBCs. Loss of RBCs is going to lead to hematuria. You will have hematuria in a patient of nephritic syndrome, while you won't usually have hematuria in nephrotic syndrome. So that is the first difference that you have between nephrotic and nephritic syndrome. Secondly, you won't have that much loss of proteins as much you had in nephrotic syndrome because you had a complete barrier that was attracting proteins, right? The basement membrane was attracting proteins, so you had an increased loss of proteins in nephrotic syndrome. In nephritic syndrome, you don't usually have any attraction. Whatever gets leaked out, that is going to be present inside your urine, right? So you don't have increased protein loss, you do have protein loss. So the protein loss is going to be less than 3.5 grams per day. That is the first thing. This is going to be your first difference between nephrotic and nephritic syndrome. Protein loss less than 3.5 grams per day. Secondly, what will you have? You will have hematuria because you have RBCs present inside your urine. Apart from hematuria, you will also have RBC casts present inside your urine, while you didn't have any of these in nephrotic syndrome. So you have RBC casts present. Apart from RBC casts, one thing that you will have in nephritic syndrome is hypertension. The patient will have hypertension because in nephritic syndrome you have salt and water retention. Now, hypertension and this salt and water retention is much more prominent compared to nephritic syndrome. So hypertension due to salt and water retention. Now, after all these things, you will have edema because you have protein loss happening. You will have edema. But how will that edema be different from nephrotic syndrome? In nephrotic syndrome, what did you have? You had generalized edema, which was also worsening into ascites and pleural effusion. While in nephritic syndrome, your edema is going to be minimal. You might have little edema or just periorbital edema, and that's it. So periorbital edema is going to be significant for nephritic syndrome because you don't have as much as protein loss as you had in nephrotic syndrome. So edema is going to be periorbital in nature, and that's it. So these are a few things that are really specific for nephritic syndrome: hematuria, RBC cast, hypertension, like periorbital edema, and protein loss of less than 3.5 grams per day. These are clear-cut differences between nephrotic and nephritic syndrome, between the presentation of the patient. And if you leave the normal glomerulus, let's just have a comparison between nephrotic syndrome glomerulus and nephritic syndrome. In nephrotic syndrome, your endothelial layer was completely fine. In nephritic syndrome, it's completely destroyed. You had charge reversal in of the basement membrane in nephrotic syndrome. You don't have any basement membrane in nephritic syndrome. You had effacement of your podocytes. Over here, you have damage to your podocytes and absent podocytes that lead to leakage of RBCs. Over here, you just had leakage of total serum proteins. So these are a few things that you should know before you go into the different diseases that come under the heading of nephrotic syndrome and nephritic syndrome. So let's talk about a few tests that you do when a patient comes to you and you suspect them of nephrotic or nephritic syndrome. So a few tests that are commonly done in patients of nephrotic and nephritic syndrome are: the first being light microscopy. You look at the glomerulus under a light microscope, and you see if there is any pathology, any deposition that you might be able to visualize. If you can't see anything on light microscopy, then you go for electron microscopy. On electron microscopy, it's usually more magnified compared to light microscopy, to see maybe there might be a small pathology that you missed on light microscopy. And after this, you also go for immunofluorescence, because in immunofluorescence you're able to visualize any antibodies that might be deposited inside your glomerulus. So through immunofluorescence you can identify that. So these are a few diagnostic tests that you run. So this was nephrotic syndrome. I'll just write it down over here, that this is what happens in nephrotic syndrome, and this was your nephritic syndrome. So I hope that basic differences between nephrotic and nephritic were clear. And if there are any confusions, feel free to write them down in the comment section or reach out to us on our Facebook page. Thank you so much for watching.